We'll be talking today about rolling out HPV testing for cervical screening and treatment, experience from a multi-country project. My name is Heather White. I'm the Executive Director at Together for Health. Thank you very much for joining. We'll just wait just a few more moments as people log on. Thank you. Hi, everyone. Welcome to the webinar. We're going to go ahead and get started. My name is Heather White. I'm the Executive Director at Together for Health. I'm pleased to welcome you to Together's ongoing webinar series highlighting numerous topics in global cervical cancer prevention and control. Today's webinar will focus on investments made by Unitaid in secondary prevention of cervical cancer through the Clinton Health Access Initiative and the Success Project to expand access to effective tools to improve cervical cancer screening and pre-cancer treatment. We'll hear from public health leaders in both Uganda and Zimbabwe who will describe their experiences in rolling out an expansion of HPV testing and preventive treatment. And could I just ask everyone to mute if you're not speaking, please? Following the presentations, we'll open the discussion for questions, and I encourage you all to share questions and comments with our presenter. We actually are doing 45 minutes of Q&A today, so we will have plenty of time to answer questions. So please do share your questions in the Q&A box as we go along. If you have a question, presenters, as I said, please share in the Q&A box. Following the presentation, we'll be sending the recording to everyone who is registered today for the event. And please do reach out to us to let us know if there are other topics that you would like for us to share with you in this series. And with that, we'll get started. I'd like to first welcome Karen Harahan and Owen Demke from Clinton Health Access Initiative. Karen currently leads CHI's work on cervical cancer, secondary prevention, and nutrition. She's a public health professional by training, and she's been working across a range of programs at CHI since 2008. Prior to joining CHI, she worked in Tanzania and in India. She's based in New York. Owen Demke is an associate director on CHI's diagnostics team. In this role, he leads the market shaping and supply side engagement for cervical cancer diagnostics and provides strategic guidance to 9 countries scaling up HPV testing. He currently oversees a team providing on-the-ground implementation and strategy support on COVID-19 diagnostics to ministries of health in the sub-Saharan Africa region. Previously, he supported implementation and scale-up of point-of-care HIV diagnostics in Tanzania, Uganda, and DRC. Before joining CHI, he worked as a consultant in life sciences, market research, and as the laboratory scientist focused on microbiology research at the University of Chicago, and is a chemist by trade. Owen is based in Kigali, Rwanda. And with that, I'll turn it over to Karen and Owen for their presentation. Thank you.
Thanks so much, Heather. It's a pleasure to be here today and to see so many folks joining the webinar. We're glad to be able to share some of our experience from our project, and then really are looking forward to a good discussion and Q&A as we think about how we can all work together to take cervical cancer screening and treatment to scale. First slide, please. You could go to the next slide, please. Great. So cervical cancer is an extremely challenging and painful disease, and it gives us multiple opportunities to interrupt the progression from HPV infection to cancer. We have an opportunity to interrupt the infection with HPV through vaccination with HPV vaccines, also known as primary prevention. We can step in after HPV infection has progressed to precancer, but before that precancer has progressed to cancer, at which point it's quite straightforward to treat precancer and prevent progression into cancer, and that's known as secondary prevention. And then, of course, importantly, we can treat cancer itself, especially as it's diagnosed and caught at early stages, and as we're able to work and strengthen the systems available for cancer treatment, tertiary prevention. So we have multiple opportunities to interrupt progression of disease. Women living with HIV are 6 times more likely to develop cervical cancer than women who are HIV negative. They're both more susceptible to HPV infection and experience more rapid progression from HPV infection to invasive cancer. And yet we have effective prevention tools available that can interrupt this progression of disease, and these tools are equally effective among women living with HIV. Next slide, please. What's so devastating about cervical cancer now, and what's motivated many of us to really work in this space, is the highly inequitable burden of disease, because access to these key prevention services is so unequal around the world. Many, many places do not have access to HPV vaccination, do not have access to effective services to screen and treat for precancer, and have limited access to services for cancer treatment. And so we see that more than 90% of the 340,000 estimated annual deaths from cervical cancer are occurring in low and lower middle income countries. It's really stark to see on this map how disparate the burden is among countries. And this is truly driven by access to prevention services that are quite straightforward to provide and roll out, and really a moral imperative for all of us to do more to prevent these cases around the world. Next slide, please. So a few years ago, the World Health Organization put forward an ambitious call to action to eliminate cervical cancer. And their strategy rests on 3 pillars across these 3 different ways of preventing deaths due to cervical cancer. 90% of girls being fully vaccinated with the HPV vaccine, 70% of women screened using a high-performance test at least 2 times in their lives by 35 years and again by 45 years, and 90% of all women identified with cervical cancer getting treatment. And if we're able to implement this strategy, we could save more than 62 million lives in the next 100 years, that otherwise we're going to be continuing to lose women to cervical cancer. Our specific project that we'll be talking more about today has been focused on secondary prevention, screening and treatment for precancerous lesions, screening with either an HPV test or visual inspection with acetic acid, ensuring that women who screen positive get triage as needed, and then treated for their lesions, either with thermal ablation or cryotherapy, or in the case of more advanced lesions, they're getting referred for LEAP. And then, of course, we always pick up some cases of suspected cancer. And part of secondary prevention is ensuring referral of those suspected cases onward for diagnosis and treatment. Next slide, please. So we've been working for the past 3 years with support from Unitaid to help address barriers to access in the cervical cancer secondary prevention space. And there are a number of challenges that we had identified from the outset of the project that really needed a concerted effort, both at the global level and at country level, to really drive rollout of high quality, effective, cost-effective tools for screening and treatment. And so this work has spanned across the access barriers shown here, addressing affordability, supply and delivery, demand and adoption, and innovation and availability. And within the scope of the program that Chai has been implementing with support from Unitaid, we've been identifying ways to expand access to screening services, again, both with HPV testing and with VIA, improving access to treatment for precancer using thermal ablation and LEAP devices, strengthening patient management, referral, and patient tracking systems to ensure that women who screen positive are getting the treatment or referrals that they need, and finally, creating conditions for scale up and sustainability, which includes sharing out lessons from the work we've been doing in these focal countries. And so we very much welcome the opportunity to share and discuss the lessons that we're learning and aim to support other countries to take this work forward as well. Next slide, please. So our project has worked with national and state government partners across 10 countries to map out appropriate delivery models to reach women with cervical cancer prevention services. And over the past 3.5 years now, we have reached almost 1 million women, or almost at the 1 million women mark for total women screened. We've increased the rate of treatment of screen positive women from about 50% at baseline to now more than 80%, and some countries have already hit 90% treatment coverage for screen positive women. And I would highlight here that this is very much thanks to the rollout of thermal ablation devices, which we discussed on a previous webinar, and which we're happy to share more information about today as well, because we've really seen this as a key intervention to help increase the rate of treatment of screen positive women. We've been offering integrated service delivery at almost all sites, 97% of sites. And we've seen a lot of progress in the prices of the key tools that we've been using. Thanks to the investment from Unitaid and our negotiations with suppliers, we've been able to negotiate HPV testing prices down below $9 on average across countries. And then this represented a 40% price reduction. And we negotiated prices for the thermal ablation devices at less than $1,000 per device, representing a 45% price reduction. And we're happy to speak more to those pricing deals. Before I move on, I understand one of our colleagues from Unitaid is on the line and would like to welcome her. Azadeh, if you'd like to say a few words about the overall Unitaid investment, I would welcome any context you'd like to share on the work that Unitaid's been doing across CHA and Success and with the World Health Organization to really support the drive towards expanded access to cervical cancer screening and treatment.
Hi, thanks so much for that, Karen. I didn't expect to be speaking. I thought I would just be listening in because it's really important work. But in terms of our investment to date, I think you've already touched on the fact that through the CHI grant, we're working across these 10 countries and being able to demonstrate different models of screen and treat. We have another 4 countries through the Success grant where JPIGO and UICC are the other 2 partners in that consortium. And our areas of focus, again, as you've already mentioned, are being able to look at increasing access to the tools needed for cervical cancer screen and treat. And that's both in terms of reducing the prices of HPV screen tests, reducing the price of thermal ablation, but also really looking at optimizing some of the laboratory workflows, for example, and working with governments to make sure that they have good plans, costed plans in place in order to be able to take these demonstration models to scale. I'll stop there, but happy to answer any questions. Thanks.
Thanks so much, Azadeh. I'm glad you could join us. Great. Well, I'll be happy to pass now over to Owen to speak a bit more about our work on HPV testing specifically. Owen?
Great, thank you. Yeah, and as Karen mentioned, really our program and the program supported through Unitaid is pretty comprehensive and touches on a lot of the different pieces across the screening and treatment cascade for cervical cancer secondary prevention. But we want to take this time to shift into a discussion on HPV testing, specifically as in 2021, WHO released new guidance that really recommends HPV testing as the preferred primary screening modality for secondary prevention. And so we'll talk a little bit about what that program has looked like so far, some learnings, and really where that work is going to. And you can see some examples that both the Uganda and Zimbabwe teams will share on this. Next slide, please. So to start with, the overall rationale and work around HPV testing links closely to an existing platform or existing footprint of molecular testing devices and platforms that exist across the world. And in a recent mapping across low and middle income countries, this kind of testing infrastructure, we found to have, there's over 17,000 of these platforms placed in public health programs that equates to about 14 million tests per week, a capacity to test that much. And so you can see that there's a lot of space to leverage existing infrastructure without needing to add on additional systems to start offering HPV testing and linking in with other programs that are already well established, HIV, TB, and other programs. And next slide, please. And so this links well, especially if we consider some of the HIV programs that have been well established over the recent years, specifically in sub-Saharan Africa, or TB programs that have been built up in Southeast Asia or PAHO regions. And so a lot of the devices that have been utilized here are listed that are listed on this slide are technologies that are a bit more automated to run. They're easier to utilize and allow for larger scale up of testing. And what we've seen over the recent years is that there's been some substantial price reductions for these assays. We know HPV test price is a big barrier to implementation. And so there have been price reductions of anywhere from 25 to almost 50% across these tests. And this allows for the ability for programs to start including HPV tests into existing budgets and start transitioning into a sustainable model for providing HPV testing. Next slide. So now with this existing testing capacity, we talked about the available WHO guidance. CHAI, through the support from Unitaid, started by conducting a number of pilots in 5 countries in sub-Saharan Africa. And you can see some of the results of this initial pilot listed here. The pilot was about 1.5 years in total, over 15,000 HPV tests provided. And we were able to track the tests across the entire cascade of care and also look at some different types of testing models and some learnings across those. So one thing to flag here is just that overall, all of these systems leverage existing platforms, existing infrastructure. And so what you can see is that that integration was quite feasible. We were able to, and ministries were able to add HPV testing into those platforms without additional HR resources, supply chain, infrastructure, lab support. However, we saw a lot of difficulty in actually providing a same-day test, triage, and treat, meaning women that got tested on one day, it was very difficult for them to actually receive those results in the same day and then get linked on to treatment. So you can see there in the data, only about 11% of women were able to get same-day result receipt, and then when we looked at across 180 days, actually not really much difference between women that received testing from on-site testing equipment versus women that had their samples sent off to a centralized lab and come back. And there's a lot of nuances to why this might be, and we're really digging into that. But I think one of the key questions here is whether or not a centralized system, a system that has a centralized lab, can actually achieve the same type of programmatic benefit as a lab that has an on-site or a near point of care device. And both my colleagues from Zimbabwe and Uganda will talk a little bit more about what this really looks like in their context. The last thing that I want to flag on this slide is just around how this program was structured, in that we offered self-sampling and clinician sampling at all of the at most of the facilities. And we found that self-sampling was actually feasible and acceptable in public health programs. And this is one of the first times that self-sampling in many of these countries was offered at a programmatic and scalable level. And so this was a really exciting outcome from the work. Next slide, please. So finally, I want to talk through just a couple of the types of approaches, core service delivery approaches that we saw, and what some of the challenges were across those. So I talked just before this about 5 countries that were doing pilot-based studies where we were able to really dig into the data, but we, as a part of our broader program, have instituted HPV testing in 9 different countries. Now, on the sample collection, I already spoke about this, the self and clinician collection. One thing that was really interesting to see is that when women were offered the option of self-sampling or clinician-based collection, we saw about a 60% acceptance rate or preference for self-sampling. Now, on these 2 different models that I just mentioned, the models where women were tested with on-site testing capacity or samples were referred out and had to come back. As I mentioned, the same day result return was very difficult, but a lot of the challenges actually came down to in-lab issues. There were backlogs because of device breakdowns, high demand, especially at the time because of COVID testing. And so there's a lot of work that we think needs to happen around optimization of what's happening in these labs to make sure that as you add HPV testing volumes, you can actually still achieve high rates of result return and linkage to appropriate treatment. Now, on the result return side, a number of different models were instituted. Some of these included scheduling appointments for women when we knew the results were actually likely to be ready. This was really helpful because it allowed us to get away from the uncertainty of women potentially coming back and results not being ready, but actually scheduling ahead of time and making sure that those results would be there. And that helped a lot with result return rates. And some of the other models, and the Uganda team will mention this, but there were applications, even adding stickers to patient files. So when women came back for their annual or for their ART visits, there was a flag to the healthcare worker that those results were ready. So lots of different kinds of approaches to ensure result return. And then finally, and we touched on it on other slides, but just market conditions have changed. They will continue to change, but we've seen some learnings here where country-led negotiations really helped to make sure that pricing was what was necessary for scale up in that individual country. And so leveraging some of the global agreements that we talked about, but then taking that to the country level and saying, what is our actual demand? And being able to have conversations with suppliers directly so that the suppliers had visibility on demand and expected forecasts, and were able to adjust and align pricing with what the country could afford. So with that, I will hand it over to Simba from the Zimbabwe team to talk a little bit more about this work. Thanks.
Thank you. I guess, and I'll just take it from where you left off and run through experiences in Uganda and in Zimbabwe. When we look at the Uganda situation, cervical cancer is one of the leading gynecological malignancies there. And I worked with the Ministry of Health there to set up a screening program there. Their target was to reach 50% of the women who are between the ages of 25 and 49 by 2027. And the current rate of screening was 10%. And very similar to what we've seen across the countries, Uganda, like Zimbabwe, adopted optimal tools to screen and provide treatment. So that's introducing HPV testing, including this in the national guidelines, and in the downstream, including thermal ablation for the treatment of precancerous lesions. And a key thing that was there in Uganda is that they had integrated models. That's a near POC, which is using the gene expert, and a centralized system, which was using the Hologic. And later in the discussion, we probably want to look at the benefits across the two different models, which is the central testing and the near POC testing. And when we look at the current statistics, 32,000 women were screened with Unitaid support using the HPV testing, and 53,000 received VIA. And the linkage to treatment was at 89%. And in addition, just to probably add on to the benefits from the Unitaid investment, they received 250 portable thermal ablation devices, which were for the screening downstream. The workflows in Uganda involved, next slide, please. The next slide. So the workflow in Uganda, since the study was set up with a focus on women living with HIV, screening would happen in the art clinic, and eligible women, after counseling and giving consent, would then be taught how to collect their sample, or they'd have a midwife collect the sample for them, and they'd get samples sent to the lab on the same day. And again, as Owen was alluding to, depending on the workflows at the lab and the backlogs that were there, testing would either happen on the same day, or it would be scheduled within the near days, maybe 1, 2, 3 days after that. And when the results are back, they'd then be either called or an SMS for the women to come back for the results. And when we look at the Gene Expert or the near POC testing platform, the advantage though is that a test can happen immediately. Same day results are possible, and linkage care can happen immediately, and it minimizes logistical delays that would happen because of transport systems. It's easier to actually track the sample in there with the same place and at. However, different from the setup that we had in Zimbabwe, and I'll get to that later. Moving to the next slide.
I'm sorry, I just want to make sure. Is that background noise coming from your side?
No.
Okay, let's see if we can mute all of our yes. Sorry, just one moment. Let's see if we can get to Simba back on the line. Apologies.
Okay, can you hear me now? Am I audible?
Yes.
Yes. So also just to maybe recap, we're looking at the Uganda situation, and then we're going to compare that with how that the same work was done in Zimbabwe. So the challenges that were faced in Uganda were around the limited capacity on the Gene Expert. There were backlogs in the laboratory. It was not always possible to get results on the same day, which then also affects linkage to care. And when you look at the clientele that's coming in, they're not really at the same level of education, and some women would get it quicker, others it would take a longer time, and this would also speak to the quality of sample, and this would lead to issues like the lab not accepting certain samples because there's insufficient sample that wasn't collected the right way. And some innovations that were put in place to mitigate these challenges were looking at dedicating capacity on the machines, so that if you have a 4-day work week, 1 day is dedicated to HPV testing, or to say 25% of the 8-hour day is then just dedicated to running the HPV samples. And one innovation again would be to get the higher capacity gene expert machines that run 16 modules instead of the 4 that are currently at the facility, and even spacing out to say on certain days, the only thing we do is HPV testing, which, while it is a solution, also pushes back against the goal, which is trying to get a same day test and treat using HPV testing. And then innovations around getting results back to the client would include placing stickers on patient files, automated SMSs, and actually making calls to the clients. And this was through partner support in the form of airtime. And around the education and the level of understanding of women, there was the added step where if someone showed that they weren't understanding how to get the sample properly, they'd get help from the health care worker. So moving on to the next slide. Next one again. So now zoning into Zimbabwe, which really looked at HPV testing, but from a centralized model. The study came in at an opportune time where, when we look at the country context, the country has a screening target to screen 400,000 women a year, but with the current capacity, they were reaching about 240,000 women a year. So this suboptimal screening meant that the efforts that needed to happen to increase the reach of cervical cancer screening and centralized testing played a huge role on this. In addition to the suboptimal screening rates, there was also suboptimal treatment, where before Chai started working with the Ministry of Health in Zimbabwe, of the 13% of women who had accessed a screen by 2019, only 60% of these were getting treatment. Current statistics now stand at about 20% having accessed a screen, and
it seems we may have lost Tasimba for the moment. Let's see if he joins. I don't know, folks from the Chai team, if there's anyone who can step in while we work to get Tasimba back on the line.
Yes, I can step in. Thanks. Great, and apologies, everyone. So I think just to finish off this piece, as Tasimba was walking through the overarching kind of approach in Zimbabwe, really one of the key pieces here is on the approach itself is the way that the tools and the role that the Chai team took was starting to shift the conversation around starting to develop tools and introduce both HPV test, thermal ablation devices, and get the national guidance refined so that these tools would actually be included in that guidance. We know pilot studies only go so far until you have a national program that actually looks at the tools that are made available and puts them into guidance so that you can scale them up across the system. And this has been a really key part of the program thus far. And what this achieved is that by this point, about 25,000 women have been screened using HPV tests specifically. The majority of those using self-sampling approaches. And so you can see that those numbers here. And again, what's happening, as I mentioned earlier, is that self-sampling is offered as an alternative to clinician-based sampling in most of the cases. And so this really indicates a preference from the women that are receiving care to choose the self-sampling option. Overall, the results, the treatment linkage rate around 80%. Again, the benefit here, because thermal ablation is often provided on site, it allows a much higher rate of linkage. And then overall, you see about 138 of those of the total sites are offering that treatment on site and with the thermal ablation. And you know, those sites, those 138, obviously we're seeing much higher linkage rates relative to those where treatment is either offsite or leveraging a different type of treatment technology. So a really exciting kind of investment and approach. Next slide, please.
Okay. Thank you, Owen. My internet had let me down there.
Yeah, back to you.
Okay, so quickly looking at really how Zimbabwe launched HPV testing using the centralized approach. Testing was happening at one laboratory with facilities located in different locations, collecting samples and then actually sending them to the laboratory, testing happening, and then the results coming back. Zimbabwe actually leveraged on the viral load program and did not make any additional investments to launch HPV testing. So what literally happened was the art clinic where women were coming in for routine care to get their art medication resupply was the entry point for cervical cancer screening services. So when a woman would come for her regular screening, when she's getting her viral load, the sample that's taken yearly, the screening was then offered and the sample was then collected. Both the self-collected and the clinician-collected samples were collected. And in this study, we nested a study where we validated self-collection in Zimbabwe to just see what test performance was like if the same woman had a sample collected by a healthcare worker or if she had the self-collection option where she collects her own sample. And we found that test performance between the two was very comparable. There was very close sensitivity and specificity, but however, there was a greater preference for self-collection. So you'd find that on our testing output data, 60% of the women preferred to have their samples self-collected. And this gives the woman more flexibility and more freedom. And we believe it's an innovation that will help actually increase access to screening because of those comforts. So once the sample was collected, it's transported with the same integrated sample transport mechanism that's carrying viral load samples to the same laboratory, and the samples were actually run side by side on the Hologic machine. Like you could load a rack of viral load, a rack of HPV testing. And then when looking at the diagnostic network optimization work that was done, it became clear that there's a bigger need for viral load testing. So to deal with the demand versus the capacity, HPV testing had a committed day where testing was done. So it was 1 day of the week to start with, and where there wouldn't be such a big load on the viral load needs, there'd be more testing done there. And one thing we quickly discovered was that the availability of the test doesn't mean, the client gets linked to care. So we had to work on some innovations to ensure that clients got their results. When we started the pilot study, the turnaround time from sample collection to results to client return was about 43 days. So we developed a system that uses the laboratory information management system and links it to the frontline SMS message system, which were all investments that were done on the viral load program. And this was used to actually deliver results back to the clients. And similar to that, where clients wouldn't present themselves for treatment, they'd be followed up by village healthcare workers to ensure that they do come back for treatment. So key things we learned from rolling out the centralized model is the efficiency, because most of the things in that system are things that were already on the viral load testing program. So it's the same workers, same platform, same logistical inputs, the sample transport, the results return. And the biggest advantage over the Gene Expert model is the pricing, where the test is lower than $9 compared to the $14 for the Gene Expert test. And it's very flexible. Flexible in that it's not limited to only the women who make it to get to the facility. In the Zimbabwe context, you'd find that there's still a lot of women who have to travel over 50 kilometers to get to a facility that offers HPV testing. And where samples are collected in the community or at facilities nearer to the women, and even when we look at the addition of self-collection, you'd find that the program has a wider reach, which then means that centralized testing, it actually offers the best mass screening potential when you look at setting up a national program in a country which is really a low resource setting. And this is all aided by the fact that on the Hologic, you can run up to about 500 samples in an 8-hour shift. So because of this higher throughput, you harness a lot of efficiencies that can help increase access to HPV testing. So next slide. We did, however, face challenges around demand generation, because as we increased access to women beyond women living with HIV, there's hesitance because they don't normally show up for those services. It was much easier when dealing with women who are living with HIV because of their health-seeking habits. They're always at the facility at regular intervals. And when you now look at trying to scale this up beyond the health facility setting, there's always the hesitance because of the ignorance, the misinformation, the myths that are actually out there. And to avert this, we are actually looking at doing this now, where we're strengthening community-based initiatives that use already engaged civil society organizations and community healthcare workers to increase the availability of information in the communities, and to look at how we can have screening programs that are not just tailored to women who are living with HIV. And really, when you look at the 90-70-90 goals as set by the WHO call, you find that 70% of the women who are eligible for screening are actually not the women who visit the healthcare facilities. They're actually in the communities. So there's a need to really look at our approach and tailor it with a different mindset. And when we look at the lab flows, we did have challenges initially around testing capacity. And to figure this out, we then had to dedicate 25% of the static testing capacity just to HPV testing. And this has really helped ramp up the numbers for HPV testing, as well as manage the workflow backlogs. And we're still evolving processes to ensure that results get to the women. We have set up the system with the frontline and the LIMS, and it's not yet perfect, but it has seen our turnaround time go down from 43 days to around 18 days. Ideally, we'd love to actually knock that turnaround time a few days lower than that. So overall, when we then look at the centralized testing, really focusing on a national scope, we believe that there's the potential to actually reach more women because it's not bound and localized. We pretty much could say anywhere you can send an effective transport system back and forth. The same way there have been very huge gains in the viral load programs, we can superimpose this to the HPV testing program without necessarily pouring in a lot of resources and harness the bigger yield when it comes to increasing access for cervical cancer screening. Back to you, Owen.
Great, thanks. I actually think this probably ties a good ribbon around it. Just to bring all of the approaches back together, as you can see, what Tasimba's walked through are just a couple examples of how we've looked at integrating the HPV tests into existing systems, some of the changes that have needed to be made at the lab workflow level. You know, and Tasimba just mentioning on the demand generation, this is actually a next phase of thinking beyond just facility-based testing, but are there other ways that we can leverage the existing systems to increase demand, you know, either working to identify women in the community, not just at health facilities, and what approaches are best deployed so that we can get up to that 70% screening coverage target that WHO has set out. There's still a lot of work to be done here, but we're hoping that a lot of these learnings can start to be utilized by different countries. We can still build on and try to make changes. And really, ideally, in the long run, as new strategies or even new technologies come available, there can be a multifaceted approach. You know, the different strategies we've identified, not a single one of them is a silver bullet, but rather this is a whole portfolio of different ways to approach cervical cancer secondary prevention. And we hope that different programs can think about these different tools that are at their disposal and use them for different populations, different settings, different scenarios to get up to that screening coverage rate. So with that, I think that concludes the presentations, but I know we have a Q&A session. So back to the Together team. Thanks.
Thank you, Owen, and thank you everyone for the presentations, and thanks also to you all for your patience as we worked through some of our technical challenges. I just want to remind folks, as you're listening to the presenters, please do type your questions in the Q&A box, and we'll be happy to get to as many as we can. We're going to go to 5:30. So we've got about 45 minutes now for the Q&A session. And I just want to first focus on a couple of questions that are in the Q&A box now. So Rebecca Kinney asks, regarding lab capacity, is there a need for additional training for lab workers, or is the test or platform, the capacity, the key limiting factor? And could you speak to where the HPV tests are currently being manufactured? Owen, I suppose that's your question, but feel free to.
Yeah, Tasimba, do you actually want to start on the capacity? Because I think you were just talking about that on the last slide, and it might be good to talk about your approach and how the trainings and the capacity, it's multifaceted. So if you want to talk about that briefly, and I'll just fill in the gaps, and I can talk about the manufacturing at the end.
So I could start with the HR component of this. When it comes to capacitation of the laboratory workers, training was really only directed at working with the new panels. Otherwise, the process flow, the systems, and to a large degree, some of the sample handling was very similar. The HPV test sample does have an advantage in that it's stable at room temperature, and there was no need to probably create special conditions for that. But beyond that, it was literally superimposing the same laboratory test flows they were already doing for the viral load program. So with regards to HR, it was more the machine capacity and dedicating it to a specific test rather than needing to retrain totally for the new test. So I guess that speaks to the capacity. And to then have dedicated capacity just helps in terms of prioritization of tests, where you don't have a situation where, because maybe of preference or programmatic demand, you have one test being run at the expense of the other.
Great, thank you. And Owen, would you like to speak to anything around the manufacture of the HPV tests? I know Chai has put together a great series of resources on pricing agreements and specs around the test. If you'd like to speak to those issues?
Yes, I can share that in the chat. So a lot of this the main suppliers that we work with, we had put it up on the previous slide, but the product manufacturing often is Germany, the US. It's not a lot of LMIC based manufacturing. I know that that's it's definitely a strategy looking forward for HPV tests, or even more broadly for local manufacturing approaches. So for one example of that is looking at just the collection kits themselves. And for a lot of the work here, we actually work through a local distributor out of South Africa that provides the self-collection kits across the region. And so looking to do that for different portions of the manufacturing kind of process and all the different consumables needed. But right now, the HPV tests mostly, as I said, Germany, US, and a few others. And just a quick maybe follow on to what Tasimba mentioned, a lot of the workflows, the training work, but Tasimba also talked about a network optimization approach. And this is really asking the question of where do we actually see testing demand across the entire country, across the full lab network. And there's been a lot of changes in terms of how sample transportation between a sampling site or a sample collection site and an actual testing site. You can change where those are going based off of where we expect to see demand. And there's a lot of those processes ongoing right now so that you can change and shift demand to make sure that your samples are going to the lab where there is the most space to run those tests. And it really helps to kind of even out and optimize demand across the whole network. And this is not just an HPV initiative, it's a cross test initiative, TB, HIV, viral load tests across the board. And it's something that we hope will continue as more HPV tests come into the market and start to be used by those same lab networks.
Great, thank you for those details to both of you. There's one point of clarification that I'd love for you, Owen, or someone from the country teams to speak to. And the question is, what is meant by near point of care? Could you all clarify what that term means?
Sure, let me take that quickly. So there's essentially three different types of models for offering a testing offering to a patient. You can either provide it at the point of care, i.e. right next to the patient. You collect the sample from the patient, the device or whatever system you're using is right there. So a malaria rapid test, COVID self-test, if people are familiar, though, or even just a COVID rapid test that's professional use, that would be point of care. It's happening at next to the patient. The complete opposite of that is the centralized systems, what Tasimba was talking about, where you collect the sample and then you send it to a centralized lab. That might be in Harare, that might be in Kampala, and you have to send it to where there's high throughput, but then you have to wait for the sample to come back, and then you can give the result to the patient. Now, in between that is the near point of care, and the idea is that you are not providing the test directly at the patient, at the point of patient, but you are providing the test at least on site. So if I get my sample collected in a specific clinic, there might be a lab that's still in that same facility, but it's across the other side of the facility. It takes a while, it has to go to the lab, get processed, and come back. So all of the complexities around the system required to send that sample out and back are minimized, but you're still not able to provide the patient the result right there at that very moment when you're providing care.
Thank you very much for walking folks through that. I think that's really helpful. So turning back to our questions, this one is from Dr. Ishak from Nigeria. He asks, what were the logistics for self-sample collection? How did clients get the samples and instructions? And how were the self-collected samples sent to the facilities for processing? And I believe that would be Lorraine or Tasimba.
I could go first. When we started self-sampling, initially it was done within the clinic where women would come in, they'd get health education in their waiting rooms. And after consenting, they then get given the sample and they're taught how to do the sample collection as a group and then given a private room to collect that. Initially, the health education as well as the sample collection training was done by a healthcare worker, but we have experimented with different approaches, and where we are currently, sample collection is being done in the community with training being given by a cadre who is the equivalent level of a village healthcare worker on training women how to collect the sample. And even in the privacy of their homes, they can then collect the sample and then have it transported to a hub and then to a lab. Initially, both the sample collection brush and the sample collection media were going out to the sample collection point. So if it's at an outreach facility or if it's in the community, that's where it would happen. But we're now really looking at evaluating models where dry swab sample transportation happens. This is where only the sample collection brush goes out there. And after the sample is collected, it's transported back dry to a hub and then to the lab. And then the mixing with the media is done just before testing at the laboratory.
Great.
Over.
Thank you.
Sorry, this is Lorraine here. Isaac, are you back online? Just checking. Okay. Maybe he's not. I think he had provided a response, but yeah, I think let's move. I will just type the answer in the interest of time. Over.
Okay, thanks to both of you, and welcome, Lorraine from Uganda. It's great to have you on the line as well. Just to continue through our list of questions, this one comes from Ellen Starr from Grounds for Health. She writes, we're hoping to transition our HPV self-sampling program to the campaign-based screen and treat model that we've used for the past few years in our VIA program. I'm curious if anyone has had experience using portable PCR equipment and less experienced lab staff to access very remote communities in a same-day treatment model. Looking forward to Simba and or Lorraine or others, please chime in on that question. Thank you.
So we have had some exposure to the smaller PCR machines. One is PeerGen, the other is Sanshore. That can be really carried out in an outreach setting, and evaluation is still going on. Uptake of them is on the cards, but there are some challenges that we noticed around really the special techniques that you'd need for them. Say with the PeerGen, the pipetting process, which really has to be accurate, and the fact that you'd have to wait for a batch of 96 tests per a test kit, as it were, which then doesn't really make it a point of care. So while we're still validating those for a different use case, we still believe that there's a lot of untapped potential in the centralized testing. So really, we'd be looking at validating some of the bigger platforms like the Roche, the ABOT, in addition to increasing the coverage on the Hologic. Because when we look at it from a numbers perspective, it seems to be something that could give a bigger yield. I think over to you, Lorraine or Isaac.
Yeah, I won't be able to speak to that. I think Isaac would be able to provide better context. So yeah, over.
Okay, maybe just a last comment. Oh, Isaac, come in, please. Sorry.
Yeah, just so at the moment from the Ugandan side, we do not have any experience with the portable PCR machines, and we're still relying on those that are really facility-based. So I wouldn't really have much to comment in that regard. What we try to do for those remote communities is to bring the samples to the facilities as opposed to following it up to do point of care testing at the community.
Yeah, thanks, Isaac. I think that's a great example of the fact that what self-sampling offers and the ability of what Tasimba said about existing infrastructure that has available capacity is that we can bring samples out, we can test women in the community and then bring that back and do testing at a central level. Now, this is all to be said, this is what's currently available. There are a lot of different entities and manufacturers looking at more true point of care options. Some of the ones that are currently in the market, as Tasimba mentioned, there are other challenges that come with those, and they're actually often not true point of care because of the complexities. But we are looking, and we do see a lot of value for the use case of being able to provide a test to a woman, collect the sample, provide the test, give the results, and ideally even provide treatment all in that one moment, in that one single visit. So we're actively looking at the pipeline. I know Unitaid is doing a concerted landscape review to be able to kind of inform and guide this broader process. And so I welcome everyone to look out for and look at the pipeline of technologies coming in and to see if there's actually potential for a more true point of care option. But right now, we don't see anything that's currently in the market that allows for this at a streamlined level.
Great, thank you everyone for those responses, and welcome Isaac. I think we have now the full contingent on the line, so we're very pleased to have you join and have everyone with us. I have a few questions that came through for us in the past several days, and one of the questions is, what was the algorithm followed for clients found to be HPV positive? And I know we talked through that on the presentation, but I thought it would be helpful just to walk folks through the algorithm used one more time, if you wouldn't mind. Over.
Yep, thanks, Heather. So I'm glad to speak to this one. So in most of the countries we work, national guidelines recommend a triage step after an HPV positive result. So after a woman screens positive for HPV, she receives her test result and then receives a triage with visual inspection with acetic acid. And then based on the results of that exam, she may receive thermal ablation, she may be referred for a LEAP, or she could be referred for suspected invasive cancer. And then we do have systems in place to track through following that woman to ensure she gets the appropriate next steps in terms of returning for her results, returning for triage, and then getting the appropriate treatment steps. And so we're able to track progress against the treatment coverage rate. It's not perfect, but we have been really working with countries to set up the systems to increase the rate of treatment of screen positive women and ensure that those women who are referred for suspected invasive cancer are getting to their referral visits and getting the appropriate care.
Sorry, I don't know if you heard me, but I was just asking, Karen, thank you for those details. Could you speak a little bit to the issue of how women were followed through, particularly through the referral part of the continuum and treatment? Were patient navigators used? Were you conferring with doctors from follow-on visits, et cetera? I'd just love to hear a little bit more about that piece of the continuum of care, if anyone could speak to that. Over.
Sure. Yep. The patient navigation systems vary by country. We've worked to build on existing systems. Let me welcome either Isaac or Tasimba to speak about how it works in their country settings.
I could take it from the Zimbabwe context. So after the HPV results were out, initially we'd wait for a physical copy of the results to get back to the facility. And once the nurses would get the results, they would then call the clients to come in if the result was HPV positive. If it was HPV negative, the result would just be put in the file and the patient would get the result when they come in for their next visit, which was likely after a 3-month period. However, when COVID set in, they were now giving longer refill courses, 6 months, 1-year courses, and we then had to innovate in that space. And that's when we started using the SMS system to say the clients would get a coded SMS, which if the message said your result is out, that would have be something that would be read as a negative result. But if it says your results are available and you need to come to the facility immediately, that is what you'd get if it's a positive result. And we'd give the client some time to actually come back to the clinic. And if after 1 week the client has not come for their result, the nurses would then do follow-up calls. After 3 follow-up calls and no visit from the client, they would then activate the village healthcare workers who then physically go to the area where the women stay, and they'd have this information from the demographic data they take when the patient consents for testing. And then they actually pay them a visit to encourage them and give them the nudge to come back to the facility. And that's pretty much how that follow-up cascade was set up. In the case where more complicated treatment was required, a referral would happen, and then there'd be a follow-up with the referral facility to find out if the patient had come. And when they do come, there'd be a feedback loop back to the referring facility. Yeah, so that's pretty much how the linkage to care piece has been happening.
Great, thank you very much. Just one quick follow-up question from Dr. Shobha Krishnan. What percentage of women came back for treatment in a two-tiered or multi-step approach versus a single screen and treat visit? If anyone could speak to that issue.
Zimbabwe has a 10% loss to follow-up. So there was 10% of the women who didn't make it back to the referral cascade. I think I can hand over to Isaac.
Great, Isaac, can you hear us? Just wondering if you could share your loss to follow-up rate for women who were needed treatment.
Uh,
Oh, I'm afraid we're not able to hear Isaac at the moment. He may come back. We'll try to get back to that question if we can. I do have another question with respect to some of the practical issues around use of the HPV testing platforms. We have a question from Jeffrey Luwe, who asks, electricity inconsistency can be a challenge for sample processing on GeneXpert and other platforms. What was experienced during this study with respect to electrical inconsistencies, and what measures were taken to address the problem, if there was indeed a problem? I'll hand that over to the country teams.
So before starting the study in Zimbabwe, we supported the facility that we were working with backup capacity. So they did have a generator on site, but then we came in with fuel support. And I think in addition to that, we put in a changeover switch. to ensure that in the event of a power cut, there wouldn't be any interruptions in the testing. So that was a big challenge, which we had seen before starting the study on the viral load program, where if there was a power cut and you have 300 samples running, all of those would be be declared null and void in that run, which was really eating into the resource base. So it was a wiser investment to beef up the backup power and not have to deal with the interruptions that the power cuts cause.
Sure. Thank you for that. I just want to see if Isaac was able to come back online so he could perhaps answer the question around loss to follow-up. Okay, great. Oh, and I'll hand that question over to you then.
Great, thanks. And maybe to expand. Oh, Isaac, please go ahead.
Wondering, are you able to hear me? My network is really messed up.
Yes,
Can
Isaac.
you hear me? Anyone?
We can hear you. Yes.
Yes, so I was just saying for the Ugandan context, with support from PEPFAR, we're able to facilitate the health workers with some airtime. So once they received the results from the lab, they did follow-up calls, especially, of course, prioritizing those women with high-risk HPV positive results. And they would be called to come back for treatment. But also late last year in December, CHAI supported introduction of an automated SMS notification system, which we call the lab result delivery system, that once the results are ready from the lab people are able to trigger an automatic notification that goes to both the mother and the health worker, sort of like prompting them to follow up on their results. For example, to the mother, it says, your results are ready, please visit your facility. And then to the health worker, it also tells them that the results for a particular patient that they requested for are ready. And so they are able to follow up with the laboratory to be able to take on the next step. So that's the current system that is working on, but the electronic system is just a pilot in about 12 facilities, whereas the rest of the facilities really rely on the health worker having to follow up with the patient, because we believe that we don't have to wait until their next routine visit for ARVs, especially when they are high risk HPV positive. Thank you.
Thank you, Isaac, for that. And Owen, did you want to comment either on loss to follow-up or the issues around power inconsistencies?
Sure. I guess just to add on to what they've shared from a couple other country examples. So there was an earlier question that was about the algorithm. And so in Senegal, actually, the algorithm is a test and treat approach. There's so anyone that is HPV positive is offered, is provided the appropriate treatment based off of a review of what treatment is necessary at that time. And so you'll see in Senegal, we've actually seen pretty high linkage rates to treatment because thermal ablation is often on site. That VIA triage step is not required or utilized within that country's algorithm. So that has helped the process a bit. But again, as Isaac and Tasimba are talking about, really where we see most of the breakdown in the cascade is before the results are returned to the patient. It's not actually between the VIA triage step and the subsequent treatment, because thermal ablation is often on site. Obviously not all women are receiving thermal ablation, but still that on-site treatment has really allowed us to be anywhere between 80 to 90% of linkage for women that are screen positive. And then finally, I think one of the highest rates of linkage that we've seen is in Rwanda, where similar to Uganda, there's a lot of follow-up directly with the individual patients, with the women directly, but oftentimes that follow-up is done through community health workers as well. And so if women are not coming back in just from the outreach from the healthcare worker at the facility, there are community health workers that are linked to the community that will do their own direct outreach, either in the community directly or through their own channels. And we've seen, because of that very high linkage rates, that for result return and subsequent linkage to care.
Fantastic. Thanks for providing those additional details and context. That's a nice segue to a question that we have open in the queue, which is in the point of care program, how did clients respond to the opportunity to have treatment on the same day? Was there any hesitation, or did clients decline? And if so, what were some of the reasons for declining? I'm not sure if folks could speak to that, but if you could, that would be fantastic.
Yeah, thank you. I think for the Ugandan context, there was not really any hesitancy to taking up treatment. Most of them actually were appreciative. Those that had a rare chance of having a same day result delivered and also a possibility of treatment easily embraced it up. But there were few cases, a few isolated cases, especially around consent to the method of treatment, where the women needed to have their husbands consent to the method. I think there were a couple of cases where certain men could not consent to the treatment because they thought it had implications, especially on the reproductive functions of their wives. Other than that, really, it was an issue of counseling the patient and reassuring them of how useful the treatment would be, but also on what sort of potential side effects to expect, but also just to have methods in place, especially to stop bleeding, which was a common post-procedural outcome, especially for the case of LEAP. Otherwise, the general experience with the opportunity, especially when the counseling session is really done well.
Great. Thank you for those details, Isaac. I appreciate those. One question coming in is, how were results given to women who did not have phones?
Yeah, so in the Ugandan context, in case you didn't have a phone, they would get contact for the next of kin. And then just to again emphasize, the results were not given by phone, but a phone was used as a method to notify them of the results. Because again, the team was cognizant of the fact that some of these results could cause unnecessary tension in the patient, especially if you send them a message to say they're positive. But once it would just notify them, and then they would have to come back to get the actual result from the facility. Thank you.
Great. And Owen, did you want to comment further on that?
Sure. I was just going to talk about a different model that was also put in place. So in Senegal and Kenya, proactive scheduling was also done so that women were told to come back to receive results on a very specific day. In Senegal, that was actually great because there was a lot of expectation and clarity on when the results would be made available. So a lot of times outreach actually didn't even have to go out to the women because they were told to come back in 3 days' time or the next day, depending on what was expected for the lab turnaround. And they received the results when they came back in. In Kenya, there was more of a conflict with that just because of some of the challenges that Tasimba's mentioned for some lab testing, and because of COVID volumes at the time, and also some breakdowns in the lab equipment, women were scheduled to come back, and sometimes the results were not available at that time, and then subsequent outreach had to happen, which was not ideal, and there was some loss to follow up in that regard. And so I think being able to schedule proactively and know and be confident when the results will be back and available at the facility is a great way to make sure that you get the results back without requiring subsequent outreach to the women.
Sure. Thanks for those details to everyone. I just want to remind folks, we've got about 10 more minutes with our panelists. So if you do have a question, please do use the chat, the Q&A function, and we'd be happy to respond to those. I just have a quick question with respect to demand generation strategies. Could you all speak to what sort of communication channels you used in advertising these programs, both for, I guess, across a broader population, so women living with HIV, and then I think I heard you all say that other women were also invited for screening. Could you just speak a bit about your demand creation strategies? Over.
Jacinda or Isaac, could you take this?
So initially on the demand generation, the focus was to women who are routinely coming to the healthcare facility. And as they were seeking other services, they'd get health education and get an invite to join the screening program. But as the program developed, there's been more proactive efforts to actually go out with messaging in the community to invite women to a facility to screen, and then even taking it a step further where there's efforts in the community to even get the screening and sample collection done within the community.
Yeah, and the Ugandan context is not very different from that. I think the mainstay and the most consistent has been utilizing the women that visit the health facility for any sort of service. It does not necessarily have to be for ARVs or HIV positive women, but also we've been able to use other channels, especially mass media. And recently we had the Test and Treat conference and also commemorating the Cancer Month. There were really slots on all national media platforms, especially radio and televisions, which were all used as platforms to raise awareness and the need for women to routinely do a cervical cancer screen. So it's really been a mixed approach over here.
Isaac, you dropped out for us. Hopefully we'll hear you again. The internet's not being friendly with us today.
The facility. Thank you.
Okay, great. Thanks. Thanks for those responses. Anything else on demand creation before we move on to our next question? Okay. I can see one of our guests, Rachel Namiro, has her hand up. I'm wondering if we can, Rachel, I don't know if you have access to a keyboard to type in a question. Okay, great. Great, we'll look for your question. Here it is, I see it. So Rachel's question, at what age are you doing HPV testing, and are you giving the tests to only HIV mothers or other women? Maybe I'll just ask the field teams to comment on age ranges for HPV testing.
Yeah, so for Uganda, the Ministry of Health preferred method of screening is HPV testing. For all women of reproductive age, that is 25 to 49 years old. However, because of the expenses around, HPV is prioritized for HIV positive women in the age bracket of 25 to 49. but occasionally you'll find women even below that. There's been really debates and discussions on how beneficial it will be even for women below the age of 25 years of age. But our core target group is HIV positive women, 25 to 49 for now, because of the supply issues. Otherwise, the general guidance is whenever available, HPV should be the screening method of interest or of priority.
Great, thank you, Isaac. And we just put this slide on which shows the different service delivery models across each of the countries to give a better idea of target populations and how those services were provided. We're coming up on our last few minutes of questions. I just want to, I see a question coming in again from Dr. Ishak. Let's take that question, and then I have a couple of questions for CHAI's global team before we sign off. Let's see, despite HPV testing being the most cost-effective, cost of HPV testing has been recognized as a barrier to scale up. What would be your comment to a model of resource stratified secondary cervical cancer prevention for low resource settings where VIA is widely available and program capacity is scaled up to HPV depending on available resources?
Yeah, I'm glad to take this, Heather. This is a great question. And frankly, this is the reality on the ground right now, that low resource settings are using VIA primarily, and then working towards expanding access to HPV as budgets allow. And so we're excited to be able to share the experience that it is feasible and practical to expand access to HPV testing, but we do recognize that cost remains a barrier. And really, countries need support to be able to fund their cervical cancer secondary prevention scale-up plans in order to reach the 70% coverage. I would say as a teaser that we've been working on an AI-assisted method of improving the accuracy of VIA, where a provider would take a picture of the cervix with a cell phone and then have an app running on the phone that would provide a second opinion to the health worker, which really meant to improve the accuracy of VIA. And we're hoping that in the next several months, we'll be able to share more results, performance results on that. And we see that as a very high potential tool in settings where HPV is not available, and to improve the accuracy of the use of VIA for triage. So just a teaser that we're excited to be working on that. But the reality right now is that many countries are continuing to rely heavily on VIA and expanding access to HPV as resources allow.
Yeah, thanks for that, Karen. And I wanted to take a moment to ask Karen, I imagine you, just to remind folks that you all do have global pricing agreements, and you have also your white paper on thermal ablation, which also indicates pricing agreements. If you'd like to say a few words about those, and we'll make sure those links are put in the follow-up email to all folks who have registered for the call today.
Perfect. Yep. So we have resources available on the experience rolling out thermal ablation devices. And then we have publicly available pricing agreements speaking to the access to pricing for the thermal ablation tools, as well as the HPV kits. Both of those resources are available at the bottom of the cervical cancer elimination landing page for the WHO. So I put that link in the answers to the questions. But yes, Heather, that would be great if we can also attach some of those resources and share links within the follow-up to attendees so everyone can see that. The pricing deals are widely available, but there's variation in terms of exactly which countries are included in which deals, depending on the suppliers.
Great, thank you. I'm going to take one more question for you, Karen. I'd love your thoughts. I know CHAI has evaluated the cost for scale up of these interventions in the program countries, and I'd love any final thoughts from you on the need for global financing and why it's particularly important now as countries can leverage these initial investments from Unitaid and expand more quickly and without losing momentum. I'd love just a few parting comments. And thank you to all of the panelists today.
Yeah, thanks, Heather. I think we're at an exciting moment in the cervical cancer elimination work because we have been able to prove out these effective models and tools across a wide range of country contexts in collaboration with our partner governments. And we're really at a moment where countries are ready to take this work to scale. And they're really looking for additional investments to support that. Domestic financing is always a part of that picture. In this case, really, we're helping countries look for further resources to support their scale-up plans. So appreciate the opportunity to discuss this work today and welcome folks to reach out with any more questions.
Great. Thank you again to all of our panelists. And that concludes today's webinar. We'll be sending out a link to this recording to everyone who's registered. Thank you again, and we'll see you on the next webinar. Have a great day, everyone.